withdraw mainly in a neutral position, otherwise you can harm structures within the trachea. Don't damage the patient and don't damage the scope because it can come out to be really quite expensive. What do you do if you get resistance? Well, you stop, you don't advance, and you remove potentially and you lubricate the tip even further, or you ask for assistance. Really important because you might damage the patient or damage the scope. So what do you do if there's fogging? That's pretty easy. Sometimes you just need to put an alcohol wipe. So you get one of these devices, put an alcohol wipe and just wipe the tip, and that can remove the fogging. There might be specific anti-fog that you can use as well. Or sometimes you can just lightly touch on the patient's mucosa and that clears the screen as well. Now, what do I do if there's sputum obscuring my view? So obviously in a sick patient or even a well patient, they might have some sputum plugging or collections of sputum which just get onto your tip, and that makes everything really difficult to see. So what do? I mean, the first thing I do is I might just put oxygen on the port. The oxygen can blow away sputum, whereas if I have a suction on there, suction will bring sputum closer to this very small channel here. It almost seems to be impossible to get that sputum plugging to actually be removed through this small channel. So oxygen is a great way of just blowing it away, as well as oxygenating your patient as well. Sometimes I might just remove the bronch altogether and just place a suction catheter down the endotracheal tube and suction. That just clears out the majority of secretions and then try and have another go. And other times I might use a drug like Glycopyrrolate. So Glycopyrrolate is an anti-sialyl and that just removes secretions. Okay, so what do you do if you enter the oropharynx and there's no view? Pretty much I try to optimize the position as for intubation. So I have the patient in the sniffing warning air position that's lower C-spine flexion and atlanto-occipital extension, and that way I get a really good passage down into the trachea. You might want a jaw thrust as well, and that just lifts the tongue and soft tissues off the back of the mouth. But other times I might even get my assistant to grab the tongue with a piece of gauze, and that way I can pull the tongue forward. Obviously this is tricky in a awake patient, but in a sleep patient or gently with someone, it can be very possible. So sometimes you might be able to see the structure, for example the cords, but you just can't seem to advance your scope. So you've got to change something. You just don't try repeating the same task over and over again. So what I might do is optimize the scope orientation, make sure that the scope is straight so that I don't have any kinks in it, because then rotating with a bend can be very difficult, whereas rotating with a straight scope is much easier. Maybe I've got an acute angle, so maybe I'm going orally and the angle is far more acute. I might try a nasal approach, which straightens my scope a bit better. Sometimes the conduit I'm using can be a bit narrow. For example, a Berman airway seems a bit narrower than an oversapien airway, and a Gadell provides even more open structures in the mouth to advance through. Also, trying small movements is really useful. So that's it guys, thanks for watching. We went through the features of the scope, a quick checklist, we went through all the different movements of the scope, and a few troubleshooting steps. Thank you very much.